I'd like to thank the organizers for the meeting for having me here. And we'll be talking about implantable devices for stroke prophylaxis. Even though the title of the talk says surgery, I actually do minimally invasive procedures, so it's not really surgery. But there are some similar principles, and we'll be talking about patent foraminal valley and just atrial fibrillation and the devices that correspond to each. So there's a couple of these stories out there, but there's this professional athlete. He was 31. He had just been to the Super Bowl, and he won, and then one morning he woke up with left-sided numbness, and he just kind of brushed it off. He's this 31-year-old middle linebacker for a professional football team. He's invincible, right? So he woke up at 10 o'clock, he had a headache and had left hemianopsia, and he called 911. So he got to the hospital, they couldn't deliver any treatment. And basically he had, what I'm trying to illustrate here, up top is the TE, and let me actually go back to the first slide and kind of talk about what I'm trying to show you here. And this is an echocardiogram. And on the left side of the screen is actually the right ventricle and the right atrium. And all that blood's supposed to go to the, to the lungs and then go to the left atrium. But someone injected some saline bubbles as contrast, and you can see a lot of it's escaping over to what is the left side of the heart on our right, so the left ventricle and the left atrium. So that's really abnormal. So suggesting there is a communication between the right atrium and the left atrium. And sometimes people have congenital heart defects, but it turns out that all of us were born with this little hole in our heart called the patent foraminal valley, and I only have 15 minutes, I can't explain it all. But and everyone they close, but sometimes they close better in some people than other people. And in this gentleman, his wasn't very well closed. So this is a transesophageal echocardiogram, and what you can see is that this is this floppy flap of tissue that can come loose and allow things to escape to the other side of the heart. So there's been a long history of the relevance of the patent foraminal valley to neurological symptoms, whether it be cryptogenic stroke, migraine headaches. Well, the migraine headache thing is kind of faded away, but the cryptogenic stroke has been long under investigation for over a decade. And this is a study that actually started when I was in training, and it finally was published a couple years ago, and this is the long-term data, and this is in cryptogenic stroke, segueing from Dr. Miller's speech, and you can see that first of all there are a lot of quote-unquote cryptogenic strokes, and is the patent foraminal valley relevant to it? There was a lot of retrospective data saying it was, but here we can see in a prospective study randomizing almost 1,000 patients that over long-term follow-up that there was a significant difference between people who, in amount of strokes between people who had it closed and people who just got medical therapy. And medical therapy in this group was either warfarin or aspirin or dual antiplatelet therapy, included a lot of different things. And this is kind of like a Kaplan-Meier curve. This is an estimate of recurrent ischemic strokes of undetermined cause. And one of the reasons this trial took so long to enroll is, number one, it was hard to find the patients, and the trial was long because the event rates were low. So you can see that there weren't that many bad events that were happening, but as time moved on, it looked like there were more strokes in the medical therapy group than the patent foraminal valley group, so the ones that got closed. So based on that, the device that was made by now Abbott is now FDA approved, and people are treating cryptogenic strokes. So one thing that you can see from this graph is that when you look at people who may be the selected few that benefit the most from PFO closure, it seems like if their shunt or how much blood's going through is big, you tend to benefit more. And maybe if you have this thing called atrial septal aneurysm, like a big floppy piece of tissue there, that you would tend to benefit more. Well, anyway, ultimately, this patient had his PFO closed. I didn't do it personally, but this is just an example of a PFO closure. Here we have in the heart the device that looks like those two circles with the wire between it. and then that little line there, that's the camera or an echo, an intracardiac echo, and that's how we look at the device before we release it. That's a bubble study. It shows that the device is preventing any bubbles from escaping to the other side. Now, this is kind of like a well-known story. It's published in Men's Health, but this guy, Teddy Bruschi, he recovered from his stroke and went on to play 4 more seasons in the NFL and recorded 366 tackles. So, you know, it's just one example of a patient, some of these younger patients who may have cryptogenic strokes and may have a relevant defect in their heart, like this patent foramen ovale. So switching gears, we just talked about this. This is A-fib. No P-waves, irregular. And this is what we've been talking about all day, strokes. But, you know, they also get these things, these peripheral embolisms, and sometimes they get ischemic limbs or other parts of the body lose blood flow. And certainly it's a major problem. And we just talked a lot about A-fib. There's a lot of A-fib in the country and around the world. And about 25% of strokes in elderly patients above 80 are from A-fib. Now this is a TEE, and this is just what happens. That kind of triangle thing up there, that's the left atrial appendage, and that's a large thrombus just sitting in there waiting to be ejected. So this is a very old study, but it's just remarkable, you know, what medical therapy can do for you. You see a 2/3 reduction in embolic events if you take Coumadin. But the problem with Coumadin is, for many various reasons, a lot of people don't get the medicine. So this is a Trans study, and this is across all the countries that are involved in the study. You can see the rate of patients getting anticoagulation was somewhere between 40 and 70%. So there was almost a half to a third of patients out there with AFib who were getting nothing. Now, even though you're getting medical therapy, you can still have a stroke while on medical therapy. And with vitamin K antagonists, meaning Coumadin, and these other new medicines, the DOACs, your rate of stroke is still around 2%. Now, this just reiterates the point there are a lot of patients who are eligible patients who are not getting treated. So there's a gap between being aware and actually acting on it in patients, and we're not exactly sure why that is. But over time, as education improved, the rate of anticoagulation for patients did get a little bit better in this population study. But this is from the Pinnacle Registry, this is another outpatient registry, there's still a lot of people not getting anticoagulated. So this is even after the NOACs just came out. Even with the NOACs being there, the rate of anticoagulation in this outpatient population is still 60%. And what with the flip side? Well, maybe all these patients bleed. And it seems like everyone's favorite bleeding score. There's the Atria score, there's this one. But what you can see is a lot of our complicated elderly medical patients have a lot of these problems: prior stroke, renal disease, liver disease, hypertension, and they have high rates of bleeding. And then if you look at the studies where the clinical trials where these are tested, there is quite a bit of major bleeding in both rivaroxaban, warfarin, maybe a little less than apixaban. And to compound the problems with medical therapy in older patients, not only do they have problems with compliance and adherence, but they fall down. So yet another barrier to medical therapy. And this is what we're talking about when we're talking about AFib, because most of the emboli or thrombi come from the atrial appendage. So this was like a systematic review mixed with TE data and some surgical data, which shows that a large proportion of the patients with AFib have thrombi form in their appendage. So there's a couple ways to deal with it, and I specialize in percutaneous techniques, meaning not opening the chest. So this is one way where you can ligate the atrial appendage and just obliterate it, and it just shrinks away. The only problem with this procedure, it's a little bit complicated, and when they first released it in the United States, because of some things like a dry pericardial tap just sticking a needle and trying to get into the pericardium, there was a lot of bleeding. So we're seeing fewer and fewer lariat procedures these days. But one procedure that Dr. Miller did touch on was the Watchman procedure and procedures like it. There are more generations of this device coming out. And the bottom line is this is a self-expanding device that kind of sits in the appendage and just blocks it off and seals it off. So this is one of the most well-studied devices in medical device history. It's gone to the FDA panel 3 times and it was in clinical development for greater than 10 years. And this is just the pivotal study where patients were randomized to device or medical therapy, and they randomized about 700 patients. And the patients were relatively low risk for stroke, mean CHADS-2 score of 2. And what they saw that over time was, they looked at efficacy and safety. So safety was like, bleeding and like device-related events. And safety was like, stroke or ischemic events or death. And what they saw was over time that the device group did better than the warfarin group in the long term. In the early part, because people were learning how to use the device, there were complications. But when you look at things like cardiovascular mortality and all-cause mortality, the device group did do better. Now, why is that? Well, there were definitely fewer hemorrhagic strokes in the device group. The warfarin group had more. And when you look at things like major bleeding and hemorrhagic stroke again, you can see that the major bleeding was much higher in the warfarin group. Now, it wasn't 0 in the device group, but these are people who may have been higher risk for bleeding. Again, for some reason, there were more unexplained cardiovascular deaths in the warfarin group. And the reason maybe is we found this in other cardiovascular studies, when you have bleeding, that you have more cardiovascular events for some unknown reason. Now, this is more contemporary data showing that the event rate for Watchman procedures has come down to about 2%. And the 1-year rate of stroke was very low after implantation. So this is the labeling. People at increased risk for stroke are recommended for anticoagulation therapy, are eligible for Watchman, but they have to have an appropriate rationale. Now, Medicare said, look, that's fine, but they have to be high risk for bleeding, and whoever's referring you to get the procedure, it can't be you, the implanter. It has to be someone like a neurologist or an internist or a non-partial third person who will say that, yeah, this is a good idea. So some clinical factors are, history of major bleeding. What's their anticoagulation experience like? Are their INRs always sky high or never therapeutic? Do they have medical conditions like thrombocytopenia that warrant being careful with anticoagulants? And do they have, and if they have indications for long-term anticoagulation besides A-fib, then they should stick with the anticoagulant. So this is how we do it. We look at the atrial appendage and measure it in 4 different ways, length and width. Then we take people to the cath lab, and here we have to do a transeptal puncture to get across the atrial septum in order to deliver the device. So that's a little plastic tube with a needle inside. And then we poke across, and this is us deploying the device in the left atrium, and this is what it's supposed to look like. There's a good seal around it. You can see by color that there's no color going in and out, and it's well positioned. Beforehand, you're supposed to take aspirin. Afterwards, you're supposed to be on dual antiplatelet therapy. You're supposed to be on warfarin and aspirin for 45 days. And then if we look at the device and it looks fine, then you can be on dual antiplatelet therapy for about 6 months. So in summary, for PFO and true cryptogenic strokes, like you've certainly exhausted all other etiologies, it appears that patients do derive long-term benefit with closing a patent foramen valve. Atrial fibrillation pharmacotherapy is more challenging than appreciated, and indications for Watchman implantation, including patients that are higher risk for stroke, who are suitable for short-term, but have reasons for not wanting to be on long-term anticoagulation, and they have to be anticoagulated for about 45 days. Thank you.